This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of pre-hospital care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're looking at from Frazzle to Flow, so mental focus, rehearsal and peak performance in pre-hospital care with Dr Stephen Hearns. So it's true to say that it is fundamentally important to look at shared mental models and cognitive aids, which can dramatically improve outcomes, both from performance, but also from safe practice. So today, joining us is Dr. Stephen Hearns. He's a globally respected clinician, educator, and author that sits at the intersection really of emergency medicine, human performance, and high-pressure decision-making. Stephen is a consultant in emergency aeromedical retrieval medicine, but he's also best known for his development really within Scotland's Emergency Medical Retrieval Service, or EMRS. The service is a government-funded critical care retrieval organisation that delivers advanced pre-hospital care to trauma patients throughout Scotland, and also complex critical illness in remote settings throughout the Scottish Highlands. So beyond the clinical practice, Stephen is the author of Peak Performance Under Pressure, and it's a seminal piece of work that we're really going to explore today. And it's really why experienced professionals falter under stress. And what we want to do is examine why people falter under stress today, and also how mental strategies like rehearsal and shared mental models and cognitive aids can dramatically improve outcomes. Stephen, welcome to the podcast.
Oh, listen, thank you very much. And thanks for that introduction. Really good to be speaking to you again and looking forward to this. Thank you.
It's fantastic to have you with us, actually. I guess let's just kick off and look at the psychology and the physiology, really, of focus and, you know, the high adrenaline pre-hospital care environment, which is dynamic in nature. There's the problem with the pre-hospital environment is no 12 hours are the same. You can go from 0 to 100 in literally minutes to that high acuity critical care case. Could I get you to speak to maybe what actually happens neurophysiologically when we move from composed to cognitively overwhelmed? And indeed, Stephen, how does that degradation affect working memory, situation awareness, and decision latency?
Yeah, so psychologists for over 100 years have looked at that relationship between pressure and cognitive performance, and indeed our ability to undertake complex practical tasks. And they have come up with a number of models. The one that resonates most with me and with clinicians that I work with is the Yerkes-Dodson curve. And the idea of this is that when we are in a pre-hospital situation, as the pressure increases, we get low-level release of stimulant stress hormones, adrenaline and cortisol. And up to a certain point of pressure, those act to stimulate us, to arouse us, to focus our attention, and to motivate us until we actually achieve a state of optimal cognitive performance, when we are at our best in terms of our ability to communicate, to make decisions, to lead the team and carry out practical tasks. And psychologists call that the state of flow. So up to a certain point, pressure is really good for us as clinicians in terms of making us switch on and perform at our best. But as we all know, in an emergency situation, often the pressure can increase and it can become uncontrolled. And when that happens, we get a surge in the release of adrenaline and cortisol. and our cognitive performance starts to decrease. And we move into a zone which psychologists call frazzle. And when that happens, our situational awareness narrows, our ability to form a dynamic and accurate mental model decreases, our ability to communicate with colleagues decreases, and importantly, our ability to call in information from our long-term memory, certainly for certain pieces of information, deteriorates. So, and in addition to that, what can happen is when we really face very high pressure situations, we can actually move into a zone of choking or freezing, a bit like a rabbit in the headlights moment, where we actually stop moving and we stop speaking. And we've all probably seen that in ourselves and in colleagues that we're working with. And that really is an evolved response when we're facing very large amounts of pressure and we've got very large amounts of stress hormones going around. And our brains can't actually differentiate that pressure from a professional situation from actually a historical situation where an animal or an assailant was actually trying to attack us. So that rabbit in the headlights, freezing type situation is us actually trying to play dead and to be seen as less of a threat to an assailant. So those zones of performance with moderate amounts of pressure, which cause us to switch on and focus our attention to achieve optimal cognitive performance in the zone of flow, then higher levels of pressure and stress hormones in a reduced cognitive phase of frazzle, and then even in extreme situations in this zone of freezing or choking.
Yeah, and to your point, actually, it's prudent to have that level of self-reflection and kind of feedback to understand where you are on that curve and understand where your reach is, because it is a bell-shaped curve, and once you start to descend the other side of that, overwhelm is not far away at all, and all the cognitive degradation that comes with that. You teach calm down as a framework within your core cognition courses, as a way of regaining composure when you are on that descending curve. Stephen, could I get you to walk us through that structured breathing, cognitive reframing, and indeed delegation, almost as rally points, really, to pressure relieve the situation on yourself during complex incidents?
Yeah, so what I want to teach on my courses are some practical tools that we can use when we're in that zone of frazzle to regain personal composure and to regain situational control. And a wee mnemonic for that is calm down. And those are, as I say, some practical tools that we can use. The idea of controlled breathing, just simply slowing your breathing down maybe to about 8 breaths per minute, 8 seconds per breath. And what that does is that activates our parasympathetic nervous system to try to overcome the overdrive in our sympathetic or fight or flight nervous system. The next thing they're kind of linked is articulate, is speak up to your colleagues, let them know how you're feeling. And the idea of the next few L and M is about actually getting together, having a bit of a cognitive pause, and have what I call a rally point, and trying to achieve a shared mental model within the team in terms of what actually is the problem that we're dealing with, what resources do we have in terms of skills, time, equipment, and then actually trying to create a list of actions and delegating them, particularly to cognitively offload the leader. So the next section is when you get to O, is about getting outside. And that is a term that I use for cognitive reframing. Often when we are in the midst of a high pressure situation, we're getting multiple stimuli coming into us, which act to cognitively overload us. And we start to believe that the situation is just so big and complex that it's insurmountable. But a really useful tool is cognitive reframing. And what that is basically is really simple, is actually just get yourself out of that situation, just even for 30 seconds, pretend you've got to go and make a phone call, pretend you're going to go and get a piece of equipment. And what to do is just think about something that is pleasant and is familiar to you, and then go back into the situation. It's a bit like Control Alt Delete on a computer. And personally, I find that really helpful for overcoming that zone of frazzle. The next ones are just outsourcing, and that is just about, maybe phoning up someone that is a subject matter expert if there's time to do that, but in much more simple terms, actually getting out a cognitive aid, whether that's a guideline, a checklist, or an emergency action card. And the N is just to fit in with something that sounded like calm down, and that's about nutrition and hydration for more prolonged incidents. Now, so these are tools that you can use yourself when you're in that zone of frazzle, as I say, to try and move yourself back into that zone of flow. The real challenge with this is, though, if you're in that zone of frazzle, that is your brain's evolved response to a high pressure situation when your brain actually thinks that it is facing danger, it's facing a threat. And to actually have insight into the fact that you're in the zone of frazzle and that you might be able to pull things together and get back into that zone of flow, it's actually very difficult for yourself to do that. So what is really important is that the person that you're working with, or the other people that you're working with in your team, are aware of these different phases of performance, and also that they know you well enough to pick up subtle cues that you're exhibiting. Are you becoming quiet? Are you starting to become louder? Are you speaking more quickly? Looking at your implicit nonverbal communication, even the color of your face, etc. And certainly, what I'm relying upon working with EMRS is the paramedic or the nurse that I am working with picking up on those cues, and it's they who actually take the steps to help me regain my personal composure and regain situational control. Because even though you might have these tools in your bag, to actually have insight to it yourself and actually be able to implement them is more challenging than we might imagine.
Yeah, listen, I agree with that, and absolutely. And it's one thing having head knowledge, and it's another thing having heart lived experience knowledge, where you can actually catch yourself and bring yourself back to baseline. I absolutely agree. Could you maybe speak to, because I think yourself and myself have maybe enacted just slowing your breathing, being first, to your point, being cognizant of your breathing and an elevated breathing rate and bringing it back down. But what does that do to your physiology? Could you maybe speak to what it does to your autonomic tone, to your restorative executive functions, to your clarity of thought, when you do start to slow your breathing down?
Yeah, so it does a couple of things. As I say, my understanding is that that zone of frazzle or even freezing is a hyperactivity in your sympathetic nervous system, and by controlling your breathing, it's activating your parasympathetic nervous system, which is going to reduce that hyperactivity in your sympathetic nervous system. And it's certainly, you can see it bringing, if you're wearing a heart rate monitor, you can see it bringing your heart rate down. It also acts to an extent as a form of cognitive reframing as well, because you're actually focusing on your breathing, you're focusing on doing something that is familiar and simple, and it's actually moving your focused attention away from the pressures or the stimuli of the scene around you.
So just pivoting slightly and looking at shared mental models, and if I could maybe get you to speak to really, having resourcing the room for an accurate mental model, and indeed using it as a rally point. How can leaders cumulatively align without anchoring the team to their own cognitive bias, and almost in a way, yeah, resource the room to reframe a mental model?
Yeah, so in order to deal with a situation, we all need to have a mental model. And by a mental model, I split that up into four parts. what is actually the problem that we're dealing with? What is the goal that we are trying to achieve? What resources do we have in order to make that change from problem to goal? And indeed, what are the risks that are involved in that? Maybe the risk of doing nothing or the risks of taking option A, B, or C. So problem, goal, resources, and risks. And what we want to do is if we want to work effectively as a team, it's really important that we have got a shared mental model, i.e., each member of the team thinks that the problem is the same and that the goal is the same, and we're all aware of what the resources and the risks are. Unfortunately, particularly in our world in pre-hospital care, we've got a lot of challenges to even forming an individual mental model that's accurate. The situations that we work in are dynamic. And also, when we start receiving information on the way to a job, we are, even based on what we're receiving over the radio, we are starting to form a mental model based on that. And then when we actually get there, there will be multiple pieces of information that we can focus on simultaneously. And what happens is that because different people are arriving with different levels of experience, different professional backgrounds, it might be different priorities from different members of different types of the emergency services. And also we're arriving at different times with different preceding information. You could press a pause button at any pre-hospital situation, whether there's 4 people there, 12 people there, and each person would give you a different mental model as to how they see what the problem is and what you're actually trying to achieve. It's only natural that that occurs. But if everyone has got a different mental model, that does not lend itself to collaborative, cohesive teamwork, shared decision-making, and sharing of the task load to get things done, to do the right thing for the patient or patients. So one way of overcoming that is to have a rally point, a cognitive pause, a huddle. Doesn't really matter what you call it, but that is when the time is right, maybe when there's a lull in the tempo of activity, maybe when you've gathered enough information about the patient or patients, and then you actually come together and you have a discussion or a rally point. And the goal of that is trying to achieve a shared and an accurate mental model, and then actually come up with a list of actions and delegating them to the appropriate people. Now, that it's actually quite a skill in itself, trying to carry out a rally point effectively and for it not to take too long, because when you're carrying out a rally point, you're not actually doing anything active in terms of decision making or task execution. And a key point for me is that generally the person who is in charge, or that the person who's most senior there from a clinical perspective, doesn't open that conversation with, this is what I think is wrong, this is what I think that we should do. Do you agree with that? And that is what we instinctively do at these types of scenes. By doing that, what we're doing immediately is creating a command gradient, and we're also promoting this concept of the expert halo effect. Because it could be that the person who is most senior there medically has actually got the wrong mental model, and there could be other people there who have actually got a more accurate mental model because they've noticed other things. But they will just acquiesce and they will just agree with the most senior person there, especially if they're speaking quite assertively. So in order to carry out a rally point, especially if there's a bit of time, and especially if the situation is a bit ambiguous and what needs to be done is ambiguous as well, what's much better is the person who is in charge facilitates that discussion and starts to ask each person, right, what do you think is happening? What do you think that we should do? And then after that they summarize this. In certain situations, a rally point is more like a briefing, though. If it's clear what the problem is, and if there's a tried and tested algorithmic response to it and it's time critical, what you don't want to be doing is going round the houses and asking everyone what they feel. If someone's got a VF cardiac arrest, then the person in charge has to declare that and has to delegate actions. I once heard a good mnemonic for the types of interaction that we're actually trying to achieve during these rally points. And the person that I was speaking to called them the 3 Cs. In some situations, you're bringing the group together and you're actually commanding them. This is what the problem is. This is really time critical. This is what you need to do. The next C is confirmation. It is pretty time critical here. It's not 100% clear to me what the problem is and what needs to be done, but this is what I think is wrong. This is what I think needs to be done. Can you quite quickly agree with me or disagree with me? And then the third C is collaboration, i.e. we've got a bit more time and this is a complex situation where it's not clear what's wrong or what needs to be done. And I genuinely really need all of your mental models and your opinions as to what's wrong and what needs to be done. So command, confirmation, and collaborate during these rally points.
So let's talk about delegation. You've mentioned it already, actually, Stephen, but I think a powerful concept which has come into pre-hospital critical care and indeed the HEMS ecosystem really is the concept of the pit crew concept, where there is almost to your point, a unique task which is delegated to that individual, maybe with closed loop communication. And what it does is it allows for task delegation, but also ownership of that task, and then coming back, and that's replicable within the resus bay of an emergency department or a major trauma center. Could I get you to maybe just unpack for us about how we should think about distributing tasks to optimize team cognition?
Yes, I think generally team leaders in the emergency department and in pre-hospital situations probably don't do that well. What there's a big tendency to do is over delegate to people that we know and we trust and under delegate to others who are there. So again, I think if you were to look at body camera footage of certain situations, you would probably see a number of people working really pretty frantically and being cognitively overloaded, and then other people probably during the event not actually doing a lot. So I've come up with this idea of group flow. So if we are performing optimally as an individual and we're under the right amount of pressure in terms of decision-making, communication, and task execution, and we as an individual are in that zone of flow, theoretically, an optimally performing team would have everyone under the right amount of flow for them as individuals, i.e. everyone who was present would be delegated a task or a decision that was putting them under the right amount of pressure so that they were all in that sweet spot of flow. And as a team, if you do manage to achieve that, then you're going to have a very highly performing team. Also, I really like the way that you said there about the idea of closed loop communication and its application to delegation. And that brings up the topic of flash teams. So a lot of books that are written about teamwork are written from the perspective of business. And when you have a team that you deliberately, in the cold light of day, select people to come together to form that team. And as that team is operating, people know each other's names, they know each other's skill sets. But in emergency medicine, in hospital care, and definitely in pre-hospital care, we on a daily basis work amongst flash teams or swarm teams where groups of clinicians come together to try and achieve a goal in looking after a patient or multiple patients, but we don't know these people's names. We don't know what their skill sets are. We don't know what their strengths and their weaknesses are. We might have different language and jargon to describe different things. And a big problem with delegation when that happens is that when we might ask someone at a pre-hospital scene to go and get a piece of equipment, give a medication, maybe put on a splint, or prepare for an airway management procedure. And it might be that that person doesn't actually have that skill or feels a bit rusty about it, but understandably they feel inhibited about speaking up about that. And you simply assume that once you've actually delegated that task to them, then it's going to get done. But as we all know, sometimes it doesn't. So that idea of having a terminology in your head just to make sure that that person you're asking to do something feels happy to do it, and that they confirm it in terms of closed loop communication, and also in terms of closed loop communication, once they've actually finished it, they let you know, and that they are ready to be delegated another task. Yeah, so teamwork in terms of delegation is about, for me, is trying to spread the workload amongst the whole team, and if at all possible, get everyone into their personal zone of high performance. This idea of group flow, and definitely closed loop communication for delegation is pretty essential.
Could I get you to speak to really just stepping outside the noise yourself? And I've definitely been a progenitor of this, and indeed an advocate, Stephen, of this. Is really, making consultant phone calls from people you've mentored and signed off. And indeed, I remember, multiple times stepping away from the chaos just to either make a consultant phone call or indeed make a pre-alert phone call, just release the cognitive load, really, of being in amongst what is maybe a chaotic, what is maybe a challenging pre-hospital critical care scene. How do you advise and or mentor clinicians to really do this safely in critical care, in time critical environments, without disengaging from patient care, but almost giving themselves that bandwidth to collect their thoughts?
Yeah, so that's what I would term cognitive reframing, and I think you've summed it up really well there. This idea that you're in the midst of this high pressure situation. There are multiple stimuli coming into you in terms of multiple people trying to communicate with you. You might have radios, phones going off, and obviously that there are lots of things that you're seeing as well, and you're trying to interpret that information that's coming into you. And as we all know, that can become really overwhelming. And instinctively, what we think the solution to that is to concentrate more, focus more, try and work your way through those problems. But in actual fact, certainly in my experience, a really effective way to manage that, or to kind of break that cycle of pressure, is to actually remove yourself from that situation and actually think about something really pretty simple and familiar to you, or actually carry out a simple, familiar task. And this is a concept. My understanding is that this is used for patients with anxiety as part of cognitive behavioural therapy by psychologists. And I find that really useful for myself, or indeed if I'm working with a colleague who seems to be in that zone of frazzle, actually saying to them, is there any chance you could go and get this, or could you do that, knowing that that procedure is actually simple and straightforward to them. Myself, what I'll do is sometimes I'll pretend that I'm going to make a phone call, and I'll just get myself, even go behind an ambulance or a fire tender, and actually just take myself out of that situation for 30 seconds and go back into it. But the key thing for me is you're not using that time to think about the situation. You're trying to think about something else that's pleasurable and is familiar to you, and then you go back in.
So you've often spoken about and we do talk about guidelines and indeed checklists as cognitive aids to really support that short-term decision making. But could I get you to maybe unpack for us, how does cognitive outsourcing protect against decision fatigue and error? Because I think sometimes, and you can speak to this from probably from personal experience, hour 13, hour 14, hour 15 of being on shift, and I've heard you dissect a number of cases from the EMRS system where the most challenging patient is at the end of the shift and is 3 or 4 hours beyond your shift at end. And so could I get you to maybe speak to, just how we use tools to really protect against that decision fatigue and error under fatigue and under stress?
Yeah, sure. So we'll maybe talk about the negative aspects of cognitive aids a bit later, but generally they are going to be positive. And by cognitive aids, what I'm talking about are pre-procedural checklists, such as a pre-anesthetic checklist, a pre-sedation checklist, or a leaving scene checklist. There are also emergency action cards when there's a predictable deterioration in the patient, and we need to orientate ourselves to that problem and undertake some time critical interventions to keep that patient safe and detect what the problem is. And then I suppose at a higher level, we've actually got a clinical guideline, say for asthma or anaphylaxis. So pre-procedural checklists, emergency action cards, and then maybe a service-specific clinical or a guideline or an equipment guideline. Now, I think in medicine and in pre-hospital care over the past 20 years, we have changed our mindset about these types of document and cognitive aid. I think historically people have looked upon these aids as something that would demonstrate that you maybe shouldn't be out there doing the job because you don't know your stuff and you're having to rely on these types of document. But I think on the whole, with the groups that I work with, people are becoming more accepting of these things and they are finding them positive. So from a neuroscience perspective, what we are doing when we're getting out an action card, we're actually using that as I suppose, an aid memoir. And what that means, obviously, is helping your memory. So the factual information that we store in our long-term memory, and that might be about the drugs and the drug doses to treat someone with life-threatening asthma or anaphylactic shock, is stored in part of our long-term memory called our semantic memory. And what I'm interested in is how our ability to access the different parts of our long-term memory is affected by different levels of pressure. And your semantic memory, what psychologists have found is under moderate amounts of pressure, our ability to go into that part of a long-term memory and pull those drug doses out, pull those algorithms out, actually improves. But when we're facing really high levels of pressure, we're really in that zone of Frazzle, then our ability to pull that information out of our long-term memory that we need to treat that patient and put it into our working memory, that actually decreases. So when we're facing really high amounts of pressure, that information that we have, taken the time to memorize for, examinations, for qualifications, and to deal with that high pressure situation, we can't actually rely on our ability to access that. And that is partly where these cognitive aids come in. It's being honest with ourselves that the way that our brains work means that we can't rely on that type of access to that type of information under high levels of pressure, and we need those backups. In addition to that, we're all fallible, and there are going to be multiple steps to a lot of these interventions in high pressure situations, and it's inevitable that without a cognitive aid, we may omit some of those steps. And the final thing for me about particularly pre-procedural checklists, when we are going through, say, a pre-anesthetic checklist where we're about to move to a situation where we could make that patient a lot worse. We're just about to give them drugs that are going to stop them moving. We're going to stop them breathing. We are potentially going to reduce their blood pressure. And what we're actually doing during that pre-procedural checklist is about a bit like a ritual or a routine that a high-performance athlete goes through before a competition. We've all seen that in, the summer or the Winter Olympics, the types of routines that high-performance athletes go through before they move into that high-pressure phase. And what psychologists reckon is that by going through a checklist before we're moving into a zone of potentially loss of control, is that we feel comforted by that ritual of going through that checklist because it feels familiar to us. It gives us a sense of control. But also what it's doing is it's switching other people on that are around you, that you're about to move into something that is, potentially risky, that requires focus and requires their assistance. And the final thing for me is, as Dan DeWorkis talks about in The Emergency Mind, is it makes Plan B part of the plan. So if you're about to undertake a high stakes procedure that there are risks to, by actually discussing that as part of your pre-procedural checklist, you're going to switch people on to being vigilant for the early signs of the procedure going wrong. Someone's going to declare at an early stage, and you're going to give people actions on. When we start to see this is what you're going to do, this is what I'm going to do. So there are multiple reasons why cognitive aids are extremely beneficial in high pressure situations.
Yeah, and to Stephen, to your point about building redundancy into the system and into the procedure. So, like you said, integrating Plan B so that actually, plan A doesn't go to plan, but there is a fallback, and there's system elements to that where there's another oxygen, and there might be another suction unit, there might be another blade, but you pre-briefed and you've verbalized Plan B. So there's a mental model for Plan B for redundancy within the system. So kind of rolling two questions into one, Stephen. One would be around, visualization and or mental rehearsal, and another would be the power of visualization, to really sense in a sensory way immerse you in the situation. Could you get to speak to the power of that, and and how visualizing and mentally rehearsing pediatric cardiac arrest or traumatic thoracotomies or difficult airway cases can really help, in a way, leverage your baseline knowledge, your experience, and almost bring you closer to performance when you actually have to do the skill.
Okay, so coming back to what I was talking about there about your procedural memory. So your factual knowledge is stored in your semantic memory, and access to that can deteriorate with high levels of pressure. If you have repeatedly executed a multi-step practical task to the point where you've repeatedly drilled it and it's become automatic to you, and that has been subsequently reinforced with mental visualization of task completion, that's stored in a part of our long-term memory called our procedural memory. And what psychologists have found is, under high levels of pressure, our ability to access information that's stored in our procedural memory actually improves. So when you're in the heat of the moment, if you have repeatedly executed a practical task and or you have repeatedly mentally visualized it, then our time to start that practical procedure is reduced, our time to complete it is reduced, and actually we'll complete it with less errors. It's similar to a soldier who is trained to strip down a weapon and reassemble it dozens, even hundreds of times. So in a high pressure situation, if there's a problem with their weapon, they can disassemble it, work out what the problem is, and reassemble it. So What we do when we are training in medicine and in pre-hospital care is often we are shown a technique, say, inserting an intraosseous needle. And that's something often that we might have to do, that we would have to do in a time pressured and high pressure situation. But what we'll do is we will demonstrate it to people, and they might get one or two attempts to do it on a mannequin. And then maybe 6 months later, a year later, they would be expected to carry out that task as part of, say, a pediatric or an adult resuscitation, and amongst many other decisions and practical tasks. But if we only carry out that task a couple of times, it's not going to be in our procedural memory, and we're not going to be able to access how we're doing it. And we're going to use slower, more demanding analytical cognition to try and recall what the steps were and what we do with our hands and where we find the different pieces of equipment. What is much more effective, and again, learning from outside medicine, particularly from high performance sport and from the military, is the concept of drilling. If at all possible, we want to prepare our clinicians to operate well in a high pressure situations. They really need to be going through those multiple steps of putting in that intraosseous needle dozens of times until they achieve automaticity and until it goes into our procedural memory. Now, the obvious drawback to that is that for certain things, such as maybe a thoracotomy or perimortem cesarean section, we don't have access to the equipment, the mannequins, to actually undertake that procedure dozens of times. So once we've achieved an understanding and a proficiency in that skill, then one way of, I suppose, tricking your mind or leveraging that access to a procedural memory is mental visualization, which again is really big in high performance sport and in aviation. And what that involves is simply sitting down in a quiet room with your eyes closed and in real time going through that practical procedure and really thinking about what we're going to be seeing, what are we going to be feeling with our hands, where am I going to put my hand on that scalpel or that set of forceps, what are other people, what's the patient going to be saying, or what are other people going to be saying to me, what am I going to be asking them to do. And this is really beneficial because psychologists reckon that our brains can't differentiate between actually carrying out that task physically and actually visualizing it or mentally rehearsing it. So it goes into that procedural memory and builds on that automaticity. And the real benefit for me is you can do it anywhere. You don't need anyone else to be assisting you with that drill if it's a two-person technique, and you don't need the equipment and the mannequin. So mental visualization, I think, can be really powerful. When I do it on courses, I can just see the cynicism, the skepticism in every person in the room's faces. I show some videos of high performance athletes and indeed aviators doing this, and then I give out headsets and I give out eye masks and I get people to do it, and consistently the majority of the people in the room end up really having quite an immersive experience. So I think it's a really powerful tool, costs no money, and you can do it anywhere.
Oh, that's fantastic. Absolutely. I absolutely advocate for that as well and agree with you, Stephen. So let's look at stewarding and rehearsing team dynamics. And if I could get you to really maybe speak to, just the power and the adage of posture, tone, communication style, and team interaction to elevate and maybe safeguard psychological safety, but also facilitate that coordination, that collaboration on scene, just the softer skills which actually translate to the harder skill acquisition.
Oh, listen, 100%. So I suppose there we're talking about the concept of, particularly from the leader, of mirroring. And there was a paramedic in East of England Ambulance Service gave me the term emotional contagion, which I thought was really powerful and just showed their experience and insight into this. So there are two ways of communicating with people and letting people know where you are on that performance curve. One is explicit communication, and that is just simply the words that you are saying. And then there's implicit communication, which actually sends out much stronger signals to other people in the team. And that's about the volume of your voice, the rate of you speaking, your intonation, and about your implicit communications, also your non-verbal communication, your posture, your eyes, what your forehead's doing, what your mouth's doing, what your hands are doing. And what is, I think, really important from a leadership perspective is that when you're under pressure, that you are demonstrating to people that there is pressure there, because you want them under a certain degree of pressure to be really pulling together to assist collaboratively, and you want them to be in their personal zone of high performance. But also you don't want to exaggerate the amount of pressure, and you want to give it a message that you personally are in that zone of flow as a leader, and you want to demonstrate positivity and optimism that this is a big problem, but it is surmountable if we all pull together. We can actually achieve it for this situation. And that is partly done by the words that you say, but much more in terms of your implicit communication. And we've all been in situations where the person that's in charge, or even other members of the team, start to implicitly demonstrate that they are in a zone of frazzle. They are moving into a zone of low performance, and they're over pressurized. And psychologists talk about the concept of mirroring, and again, that's an evolved response, they believe, to reduce conflict in people that we meet, that we subtly start to mimic other people's body languages and maybe the way that they are speaking. So therefore, other members of the team will start mirroring the cues in someone who is in that zone of frazzle. And then also this idea of emotional contagion, that if someone starts to demonstrate pessimism or catastrophizing, showing that they're in that zone of frazzle, then that is going to become contagious in the rest of the group. But you can spin that the other way, that even in situations that feel extremely pressured, if you have got a leader who is aware of their implicit communication, is aware of the risks of this emotional contagion, that they can demonstrate positivity and optimism, then that too is going to spread out amongst the team and is going to hopefully keep people in their personal zone of flow and not into the zone of frazzle.
So just as we come into land, actually, Stephen, on the podcast, just if I could get you to maybe finish off by just speaking to, reflection as rehearsal, and you speak of, mentally replaying events in real time to understand the stimuli and how you move with decision points. Just how can structured reflective rehearsal both accelerate learning whilst protecting clinicians from rumination or indeed moral injury?
So I think possibly we're maybe talking about two things there. One about structured debriefs, and then the other one is using mental visualization as a personal debrief. So I think there are a lot more benefits to debriefs than we actually think. Whenever I ask you, I was running a course earlier this week, and every group you say to people, right, why do we debrief? And it's to learn what we do well and to learn about things we didn't do well. There's a lot more to it than that. So you and I are out on a high pressure or traumatic job, particularly maybe something that didn't go particularly well. And as we talked about earlier on, I am going through that job and I'm creating my own mental models based on my own personal experiences, based on what I am focusing my attention on at any one point. And you're going through that based on your personal experiences, and you're focusing on different things. And also, so when we come back from that job, I am going to have a different mental model as to what happened from you have got. And in addition to that, psychologists reckon that our brains under high levels of pressure don't lay down very good long-term memories. And they reckon that's partly a protective mechanism if we go through a traumatic event. So what often happens is if we don't debrief, then we can, finish that shift and go home, having gone through that traumatic event with an incomplete, inaccurate, and a fragmented, partial memory of it. And that does not lend itself well to processing and recovering from that experience. So I think one benefit of debriefing is actually sitting down with colleagues who were there and finding out what their mental model was, what was their recollection. And we all know that. You sit there and you say, that's right, I do actually remember that happening. I didn't notice why that was happening. And by debriefing that job, you end up filling in the blanks or putting the pieces of the jigsaw together to form a more complete and an accurate picture, which I think personally really helps me as I move forward and I try to process the event subsequently. Also, there's the concept of defusing. So it might be that you and I are out looking after this patient and you say or do something which I might have, found rude, or I might have found it confusing. I might think that it actually contributed to a negative outcome for the patient. And what, again, we don't want to do is we don't want to leave that job, finish the shift, or we're still even move on to the next job. And I'm still ruminating about that. And the idea of diffusing it was someone from the Coast Guard service, the helicopter search and rescue service in the UK that told me about this. He told me that was a big thing when he's doing debriefs of jobs, is right at the outset, has someone done something here that has confused you or upset you, and you talk about that. Because what happens 9 times out of 10 is when you say, listen, I don't know why you did that. Actually, that person will explain, well, what I noticed at that point, what I was thinking at that point was this, and that's why I said or I did that. And as I say, 9 times out of 10, you'll actually go, okay, I can understand that now, and I can move on from it. So there's a lot more to debriefing than just learning about what went well and what didn't do well. To me, it's about putting the pieces together to get an accurate and more complete mental model, so that I can move on from that traumatic event.
Oh, that's fantastic. Absolutely. Absolutely. And alignment is, and to your point, just on exposing other in a good way, in a healthy way, other people's mental models so you can reframe your own. I think it's a powerful pivot, actually. Stephen, listen, thank you for your time. It's great just to review this fantastic and indeed really insightful perspective on how we move within pressured teams, and indeed how we bring teams together for mental focus, rehearsal, and peak performance. So you this is part of a core cognition number of courses that you run. We'll put core cognition within the show notes so people can go away and look at the unique offerings that Stephen runs within and courses that he runs within core cognition. I just want to thank you. We will be hearing from you again, but this is a really powerful reframer, and I think some of these tools are absolutely vital to stewarding high-performing teams. So listen, thank you so much, Stephen.
Oh, listen, thank you very much for the opportunity. I thoroughly enjoyed that. Appreciate it.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.